The definition of erectile dysfunction is a consistent and recurrent inability to acquire or sustain an erection for sufficient rigidity and duration for intersexual course. Diabetes is known as a risk factor for erectile dysfunction or ED. It's threefold higher among people with diabetes. And it could be the first sign of diabetes. Most importantly, it could be an indicator for CVDs. So we have to look for that. And it's very common. About 50% of people with diabetes may have ED in the first 10 years. It's very common if a patient has diabetes, will actually the prevalence 71. But if he has diabetes and hypertension, the prevalence is higher, 77%. So it's very common, and it could be severe, mild to moderate, or even severe in 22.9% of cases. Now the causes of ED are very known: vascular, diabetes, medication. And if we put together the three causes, it represent about 85% of all causes of EDs. Now, why is this title, A Forgotten Complication of Diabetes? First of all, because physicians don't ask about ED. They don't have enough time or more focusing on diabetes control. Sorry. Or they're not interested in ED in general. Or they believe it's some kind of a late complication, so they don't care about. And they consider sometimes their patients as very old to have a sexual activity, which is not always true. And most of patients of diabetologists now in our countries and worldwide are female who are not comfortable to deal with EDs. Patients themselves have some concern. They were not started to talk about that. They are waiting for their physician to ask about, for cultural reasons. And according to my personal experience in the Middle East, we haven't used to ask people about EDs either in hospitals or in private clinics. Even here in Europe, in France, and according to our survey in diabetes department, we have only 40% of patients with diabetes have been asked if they have ED. And so we can conclude that ED is undiagnosed or even forgotten complication of diabetes. Some causes are factors related to diabetes, like autonomic neuropathy, vascular disease, or duration of diabetes. Older diabetes has more risk to develop ED, or even poor glycemic control. Other factors are not related to diabetes, which should be seen with any other patient: age, testosterone level, dyslipidemia, frequency of sexual activity, medication, and CVDs. So since our diabetic people have all these problems, so they can develop this ED. Well, I'm not going to details of mechanism of action, but let's say to have a good and long and enough erection, we need a normal structure of our penis with spongious and cavernal corpora and arterial and venous system for good flow, blood flow, and to venous to block the exit of the blood. It's not enough. We need more than that. We have to have a sexual stimulus with connective function going through autonomic neurotransmission, sympathetic system for contraction, and parasympathetic for relaxation and initiation of erection. So it's very important to have that. Besides, there is direct stimulation with somatosensory neurotransmission by touch, direct touch of the penis. So both ways can work. We know that is connective function, particularly autonomic neurotransmission, is affected on diabetes. So we have many reasons, many causes to have erectile dysfunction on diabetes. First of all, neuropathy, which reduce sexual stimulation and not start the cognitive function with memories and visual stimulation. Also, we have vasculopathy, which will reduce the blood flow in the penis. Endothelial dysfunction is known. There is less synthesis of nitric oxide, which is the main element for initiate the cascade of generating the vasodilatation and the erection. More than that, people with diabetes will have sometimes hypogonadism, which will reduce the sexual drive and the libido. Depression is very common on diabetes. And lastly, drugs is very common. Most of our patients have many reasons, many drugs will interfere with their function, their sexual function, and reduce libido and erection. Penile tissue compliance is rare, but it could be possible. And lastly, we can say most of people with diabetes will have more than one factor to develop ED. So we have to check all these causes for that. So restoring a normal sexual life is not only about libido. It's more than that. There is lower risk of women cancer, breast cancer, prostate cancer, low back pain and migraines, fewer menopause symptoms, and maybe lower risk for heart disease, lower blood pressure, and of course, a couple are happier when they have their sexual normal life. So we start to make diagnosis with the history of ED. Is that really ED? What are the causative factors? Lifestyle, disease, drugs, other factors? Is that organic or psychogenic ED? We have to make the difference between both. We have to check what we call now International Index for Erectile Function, the version 5, which is available in many languages, also in Arabic. We have to look what the consequences of ED on quality of life and couple life and relationship. Most importantly, what the patient expecting from us regarding management of ED. All that is very important to start. If they don't need treatment or something like that, we shouldn't go further. Lifestyle can affect, of course, ED and even more male infertility. Look like obesity, smoking, alcohol cause erectile dysfunction beside decreased libido, and the problem of ejaculation is very known, and maybe diminished sperm function conducting for male infertility. So first of all, we have to make difference between psychogenic and organic ED. The psychogenic one has sudden onset, situational, also normal walking and nocturnal erection. There is some relationship problem, depression, and no penile pain most of the time. And the opposite side, organic one, have all of that. So we have to make the difference between both. We have to check what we call the International Index for Erectile Function. It's available, it's easy to answer for most of patients. In Arabic, there is no version. For other language, also, you can check your language. Physical examination is very important. Blood pressure, peripheral pulses, sign of hypogonadism, and signs of autonomic neuropathy, and finally, genital exam. Most of cases, or a lot of them, are associated with drugs. 25% of ED are caused by medication. And we know that there's a list of huge and long list of medications that our patient taking most of time: antidepressant, thiazide, dioxin, lipid-lowering agents, and so on. But we can divide them on four main classes: psychoactive one, cardiovascular, and hormonal, and others. So you have to check the medication of your patient before going further on the investigation of ED. Sometimes we need, of course, to control diabetes, check testosterone level, prolactin, FSH, and thyroid function, which is very common on diabetes. Coming now to management, we have generally general measures: psychosocial counseling, pharmacotherapy, non-pharmacological therapies, and lastly, more rarely are we arriving as last chance to surgery. So as general measures, we can, of course, try to reduce the risk to develop ED by controlling diabetes, and then make some lifestyle modifications like stop smoking, reduce alcohol, weight loss, regular exercise, and most importantly, we have to look for ED as some kind of personal problem, and we should have what we call couple counseling for this kind of problem. We have to ask if there any possibility to come with his partner to discuss the issue, not coming alone all the time. Maybe it's not easy in some countries, but here in Europe, what we are doing to ask the partner to come to discuss all the issues together. Of course, the phosphodiesterase 5 inhibitors change completely the diagnosis or prognosis and treatment of ED. We know that is the PDE5 inhibitors will inhibit the degradation of cGMP to GMP, and that cases will have more cGMP will allowed in some cascade to liberation through the nitric oxide to relaxation of smooth muscle, and with this will allowed to have more blood flow and initiate the erection. In people with diabetes, there is less nitric oxide, and then if we can use PDE5 inhibitors, we'll get more and will initiate the erection. Now we have at least four kinds of PDE5 inhibitors. The first of one, sildenafil, 25, 50, and 100, then vardenafil, tadalafil, avandafil. What the difference is only in two main points. The duration of action for tadalafil is longer and not affected by food intake. The other are shorter and affected by fatty meal. But there is difference on efficiency also. Tadalafil looks like superior in efficacy. We need to treat 2.4% of a patient, 2.4 patient to get a result. For vardenafil, we need to treat 3 patients to get some result. Of course, there is failure for PDE inhibitors. Most importantly, wrong dose, wrong timing, no direct stimulation. Since patients with diabetes will lose cognitive function, we need a direct stimulation on genital organs to get the same production and efficacy of these drugs. Food interaction, particularly with fatty meal, and drug-to-drug interaction and hypoglycemia. And this is very important. And the most reason there is no enough education for the patient themselves or for his partner. To have a sexual relationship, you need a partner And this partner have to be active and understand what's happened and how we can help. So if you have a couple counseling, it will make the result better and you will get better, of course, result. So if we don't have in diabetic patient what we call sexual stimulus by cognitive function, they have to go to direct stimulation on genital organs to get more direct, longer stimulation to get the same result. The people are less younger and the result take more time. There is some effect, side effect like headache, dyspepsia, vasodilatation, and other is very known. So we have to be careful about that and to tell your patient about. Some contraindication, most of them recent cardiovascular disease, nitrates, hypotension, some deformity of penis, and predisposition for prolonged erection in some disease. But there is also some interaction with some medication, like here, nitrate, glyceryl nitrate, angina after sedentary, and so on. So what is important to see, some list of drugs are very common and used on diabetes. Be careful about that. But sometimes there is also, beside this problem of neuropathy and vascular disease, some hypogonadism is very common on people with diabetes. We have to check that. And could, in some way, when you are treating and dealing with that, you will improve libido, sexual activity, and general. So be careful when you don't have any result with using PDE5 inhibitors. Try to check testosterone level to limit that. The other way to treat is penile self-injection of prostaglandin A1, Caberget, 5 and 40. Of course, it's work with combination sometimes with phentolamine and papaverine. It's very active, but it's more complicated, and there is some side effect with like plaque development, priapism, and pain, and some contraindication for this use, bleeding disorder, skull cells disease, and leukemia. So it's very, be careful about that. But it's very active. One PDE5 is not working. There are another one, it's intraarterial aldosterone, MUSE, less expensive and less invasive, require some massage and take more time and training, but it's very costly also. There's another way, if you don't get a result with the prostaglandin or PDE5 inhibitors, which is the vacuum device, is very good solution because it can help people, and this is will with the concentric ring at the best penis will allow erection. It take more times and it will last for 30 minutes. But it's like older people like it, it's not invasive. One cost, pay one only, and take time and practice. The erection is called in this case, and the difference of look of erection for people looks is like artificial. Some couple don't like it, and it could block the erection, the ejaculation in some patients. The last option, very really the last option, in my experience, I saw only a few cases of this surgery penile prosthesis, semi-rigid rods, 2 pieces, implantable prosthesis, or 3 pieces with a reservoir. And there is some risk of infection, destroy corpora cavernosa, or erection and mechanical failure sometimes. So now there is new development regarding association between some combination together, but we don't have a good result at long term. Now some people trying to use intensity shockwave therapy to find some result. I would arrive now to my conclusion from this presentation. I would say erectile dysfunction is an early and common and forgotten complication of diabetes. 1. 2. Our patient waiting for us to ask about them. And we can help them if we ask. If you don't have time to do that, please use IIEF5, put it in an envelope. Let the patient answer and to collect it later on without being uncomfortable, either you or your patient or nurses with that, and you can go through that. The diagnosis is very easy, and you have to think about that. My question, how many times you ask that question to your patient at the last month? If you didn't do that, maybe it's time to start, because I am saying today, your patient is waiting for you. My home take message, today we can't treat ED with good result if we think and ask about that. Thank you very much for listening.